Opioid withdrawal syndrome, it really refers to a constellation of symptoms that you can see if a patient has sudden cessation or reduction of their opioid use over a period of very long chronic use. You want to look for sympathetic hyperactivity, flu-like symptoms, and even GI symptoms. It is a subjective clinical diagnosis that can be supported using the DSM-5 criteria or the COWS criteria, which stands for the Clinical Opioid Withdrawal Scale. Your cornerstones of treatment are using methadone or buprenorphine, which I will go into later, and also, of course, psychosocial support. You first want to manage their withdrawal symptoms, and then you want to make sure they have good outpatient medication-assisted treatment programs, and you want to give patients the opportunity to reinforce harm reduction strategies and also overdose or relapse prevention. Quickly, the pathology of using opioids is binding to the mu-opioid receptor. When you acutely use an opioid, you lose norepinephrine and you have CNS depression. Then you have increased dopamine, which causes a euphoria feeling. Repeatedly using opioids, your norepinephrine levels or your CNS depression return to baseline, and this is when you start having opioid tolerance. When you withdraw from opioids, you have a sudden increase in norepinephrine, and it causes dysphoria and very hyperactive CNS. During this CNS arousal, you have sympathetic hyperactivity. So you have tachycardia, hypertension, anxiety, mydriasis, yawning, lacrimation, and hyperreflexia. The patients may even seem to have the flu. They have rhinorrhea or diaphoresis and chills and even myalgias. Oftentimes they have diarrhea and abdominal pain along with this. It can be extremely uncomfortable, but this is very high yield. It is generally not fatal unless the patient has severe dehydration or very bad electrolyte disturbances. Hospital admission is very important for patients with very severe opioid withdrawal if they are unstable or they have significant comorbidities like sepsis or polysubstance intoxication. In acute management of opioid withdrawal, you want to use a long-acting opioid agonist. If they already had maintenance therapy in the past, you can restart them on this regimen as long as you verify it. After they are acutely managed, you can start thinking about maintenance therapy. You have to encourage the patient for medication-assisted therapy using methadone or buprenorphine. You can later maybe even consider tapering from opioid agonists after having 1 full year of therapy. For patients who are really sick of opioids and they absolutely want to stop, naltrexone can also be used. Let me quickly wrap up with the different pharmacology. Methadone and buprenorphine are indicated for acute management and also maintenance therapy for preventing relapse. The difference between methadone and buprenorphine is that the risk of precipitating any type of withdrawal in methadone is none, versus buprenorphine you can. Methadone fully agonizes the mu-opioid receptor. Buprenorphine is only partial mu-opioid receptor agonist, but it has really strong affinity to the receptor compared to other agonists like methadone or heroin itself. You can start a patient on methadone even if they don't have any objective signs of opioid withdrawal, but look out for their QTC interval and you want to get an EKG. You start buprenorphine only if the patient has objective signs of opioid withdrawal. The reason why you do this is because you don't want to precipitate withdrawal by using buprenorphine. Typically in the hospital setting, you will also see buprenorphine used with naloxone. This is a competitive opioid receptor antagonist with also very high affinity to the mu-opioid receptor. You see this usually to reverse opioid overdose. The reason why we use buprenorphine with naloxone is because naloxone lowers the potential for misuse and also opioid diversion. You can also use buprenorphine in pregnancy. There are different settings that you use buprenorphine and methadone. Methadone you can see in the hospital or in a residential area that has 24-hour nursing support, and also methadone clinics, which are considered intensive outpatient withdrawal clinics. Buprenorphine, on the other hand, has to be under supervised settings. Now that we're done talking about methadone and buprenorphine, the opioid agonists, let's talk about the opioid antagonist, naltrexone. This is for maintenance therapy for patients who are no longer physically dependent on opioids, and this is very important because they also precipitate withdrawal. Before patients can even start on naltrexone, they have to be opioid free for 1 to 2 weeks just because it can precipitate withdrawal. And if the patient has a surgery coming up, they have to stop naltrexone 30 days before this planned procedure. Like with buprenorphine, naltrexone is also given in an outpatient withdrawal management setting, like some office-based program, and also you need to have supervised settings at all times.